Good afternoon, everybody. And you must have had a lot of academic knowledge which has been achieved in the last 2 days through National Thalassemia Society and its seminar at All India Institute of Medical Sciences. I am here to deliver a short talk on what's the true story with thalassemia. So, the basic of thalassemia, everybody knows it, that we have a lot of patients of thalassemia in the country, and the population is 16% of populations like Lohanas, Agarwals, Buddha, Marathas have thalassemia in the gene. That's a very big amount of people, and they are still not aware they are thalassemia. That's why we have around 10,000 children who are born with severe variant or thalassemia major, which require 15-year transfusions. There are around 6 lakh children of thalassemia major, more than 10 lakhs if you add the GB and the sickle. So, one of the stories, we need around 10-15 lakhs of blood transfusion per month for these small kids. That is around 1 crore, 1.8 crores of blood used for the same purpose. And that also doesn't lead to a normal life of them, normal life duration for them. So what is the true story for thalassemia minor have normal life, like Dr. Ramanan has, and persons with beta thalassemia major live in an average of 17 to 30 years. My data is a British, and most deaths are because of cardiac iron overload. And ultimately, by the age of 30, 40, everybody has cardiac complications. We have liver complications. All these things occur because of iron overload. Even if you are well chelated, the iron goes in your body and then comes out. The options available today for thalassemia major are blood transfusion and chelation, blood transplant, novel therapy, and gene therapy. Gene therapy is more of a theoretical discussion, which I have not entailed. Now, blood transfusion, if you do it properly, what happens is the iron slowly starts increasing after the age of 10 years. And this is the graph which shows it. This is the 10-year line. And from here, 10 years, all complications are seen. Hypogonadism, hypothyroidism, diabetes, osteoporosis I've seen in 95%, liver fibrosis, arrhythmias, cardiac failure are also not uncommon. Ultimately, cardiac diseases lead to death as such. Now, so that's why bone marrow transplant, Dr. Lucarelli at Pesaro in Italy started it. He had a brilliant response to his treatment. But remember, on average, around 25 to 45% have risk to die during the procedure, and have complications of secondary malignancies, late graft failure, chronic graft versus host disease, and infection. In the last 37 years, there are approximately, India has probably done 1,500 to 2,000 transplants for thalassemia across various centers, the Christian Medical College below. And the data there shows that class 1 has survival of 66%, class 2 surprisingly have 90%, and class 3 55%. But remember that these are over 24 months. We don't know at 5 years, 6 years what was the data as such. So, moral of the story is, if you are a class 3 thal, you have a 45% risk to your life. And in India, for unknown reasons, class 1 are not doing that fine. Class 2 are doing a little bit better. But remember, as I know, increases the risk. We know autosomal disease of graft versus host disease, graft failure, everything goes up. So ultimately, bone marrow transplant is an imperfect solution which has been offered to around 1,500 children in this country in the last 27 years, of which around 800 are still with us, and the rest are not with us, and the rest who have all the risks of secondary malignancies and other things. You may develop other malignancies after transplant. How does the transplant unit look like? This is a 3-bedded transplant that we have, which is probably going to be a bigger center in next 2 to 3 years. There's a UV pass box that you see, which is an integral part of transplant. Filtered rooms, air which is purified, water which is purified to the filter, and also a filtration plant. We have a full-fledged multimedia center inside the transplant room. Similarly, we have inside the transplant where we mix up chemotherapies. It was inaugurated by Professor Ruanor from Hadassah, and we have an ongoing relationship with them. We have got a lot of help from social organizations. We have done the first haploidentical successful. Also, from mother to child for thalassemia. And the first transplant from a sister to twin brothers was done by us. So we have a lot of patients for transplants for various indications, and with cord blood, with unrelated cord blood, with haploidentical, with sibling transplants, everything has been done at our center, and we have a decent success rate as comparable to the ones in America. Our transplant data has been accepted at international level, data on sickle cell disorders, which was published along with Alien Gluckman and the IBMTR in year 2014, leading to us having a more wider acceptance across the world, and us started the membership of the European Society of Blood and Bone Marrow Transplant, and we are reporting the same. Now coming to what is novel therapy. Novel therapy is basically a therapy which I in fact found out for my patients who get graft failure post-transplant. So that's how I stumbled upon all this treatment. And I found out if you don't have transfusions, even with medicine, you make thalassemia look like a diabetes treatment or hypertensive treatment, the patient could have a normal life. So remember that blood transfusion which are given prior to the treatment will cause anger that will be taken away by just giving the novel therapy. So there are no side effects of blood bone marrow transplant, including the mortality of the bone marrow transplant. And I always feel that the only way to avoid complication is by stopping transfusion, not by continuing them. And many studies have been done in the field of HbF, where pioneering studies have been done by somebody else, which have just used it, modulated it in the population. The initial paper of wheatgrass was by Professor R.K. Marwa from PGI Chandigarh, but it was a study of 30 patients where he used wheat and so after the paper, many patients started using wheatgrass from their backyard, their farms, and started drinking juice. But what I found is these patients did not get any help by drinking juice. That's why we came to a conclusion: probably giving powder would be more important, more useful than giving liquid. Then the last data from Iran came, and that they also showed that the promise was more in thal intermediates. But nobody has ever mentioned what are the technique that they use, what are the way. I mean, if you continue transfusing a child and also giving these medications, they're highly unlikely they will get off transfusion. So I was looking at healthy with post-allogenic transplant. There were 13 of them, and then I stumbled upon a paper by Aguilar Lopez of Mexico and of 2008, and she used this drug for 17 years, 1990 to 2007, with a dose of 75 to 100 milligram per kg, which in my perception was very high. So that's why I just reduced the dose to 5 to 10, using 2 to 10 milligram per kg for our patients. So the known side effect that people are reading about must be much lower as compared to what the paper of Aguilar Lopez was. So this is the paper. The first patient was, you can see, 1990 to 2007, and the hemoglobin steadily went up. And after using it for time, she published the paper, and this was her second paper, second paper as such edition. Paulo Ricci et al. Have published a paper saying use of thalidomide in their patient, Italian paper, which says that it's safe to use thalidomide, and the data is of more than 36 months. So this data was very, very interesting. So I used it in my graft failure. One of my patients was seropositive, HIV positive, who had undergone unrelated cord blood transplant, which graft related as soon as I started antiretroviral therapy. And then we just followed by haploidentical transplant rescue, which failed in 9 months. So she was back on transfusion, so I wanted to get her off transfusion. So I started using initially hydroxyurea, which did not help her much, and then thalidomide with wheatgrass. And we have probably 10 out of 13 patients of transfusions. And so we have got many patients in Bahrain who got transplanted with Lukari, who are doing well on our treatment. We have patients from CMC Vellore, from CMC Ludhiana, and from GCRI, Gujarat Research Institute, Ahmedabad, where the transplant failures have come to us. We have seen a 66 to 70% response with this treatment. Now, there are more than 1,000 children we are already treating, but very important, along with iron overload, the most important thing is HIV is a very big problem with blood transfusions. Everybody knows in Gujarat, an incident where 23 children at one go develop HIV. So we don't know how many of our thalassemics are getting HIV. There's not much clarity, not much data on this aspect as such. After the hydroxyurea treatment was started, we came and analyzed the data, and then we found that three things were very important. First was, when was the first transfusion? If it was less than 1 year, it was not good. If it was more than 1 year, our response was better. If the spleen size was small or was removed, it was better. If there was no use of Kelfer, the response was better. So we came with a score called thalassemia cure score, depending on giving a number to all these response criteria. And so if it was 3, it was good, and 0 was really bad. So how bad was it? So we compared the data of our old hydroxyurea. We had a publication at our national conference of 74 patients, where a score of 3 gave a response of 50% with hydroxyurea. Score of 2 to 1 gave 30%, and 0 gave 10% or less than 10%. So there is hardly any response for patients who are transfused under the age of 1 year with a large spleen and Kelfer. Thalidomide, in fact, gave us more better response. And if your score was 3, the response is as high as 90%, 2 to 1 is 60%, and 0 is 30%. Today, we have more than 25 post-transplant graft failures with around, as I told you, 70% response. Our data is going to be presented now of 200 patients with everything from mutation analysis. We have many patients with HB EDCs and sickle cell also got gratifying response, and in fact, sickling crises have come down in our homozygous sickles. We have one incident of using hydroxyurea as a patient of homozygous sickle who was on thalidomide without any problem but wanted a child. So we shifted him onto hydroxyurea, and 2 months later, they had a normal pregnancy and they delivered a normal child after 11 months. But he was put back on thalidomide after conception. And what does the study show? In our population, 48.1% have this common mutation called IVS125 with a different name today. And this is the mutation which is in fact a beta plus mutation. Very important, because if your patient has this mutation at the beginning, it's better, you could probably have a very good response. And the response rate with this mutation is around close to 80 to 90%. Similarly, the next mutation is IVS121, which also seems to have a response. So we found that IVS125 has a very encouraging response. XMN polymorphism, which we will have been talking about, did not seem to affect our as such. So we have many patients of sickle and HB beta thal with 80% response and increase in hemoglobin. We found 95% of incidence of osteoporosis in a thalassemia major cohort in spite of response to this because of a preceding iron overload. So whatever iron is accumulated will always cause the damage to remove the cations. Similarly, it always will cause a cardiac iron overload. Similarly, will cause even liver injury. So remember that it's easier said than done, that your heart will become normal if the ferritin comes normal from 10,000 comes to less than 500. Your heart, which has already been damaged with that 10,000, it cannot recover on its own. It takes time and may not recover after consecutive injury. So what I feel is this therapy of using hydroxyurea, using thalidomide, wheatgrass needs a wider usage. What we have developed is a method of causing a selective amount of hypoxia, which leads to increase erythropoietin and also help it with erythropoietin so that patients get a better, faster response. And what I feel is if we are able to put at least 60% of our population of thalassemia off blood transfusion, we save nothing less than 4 lakh bags per month for the nation, maybe more, 10 lakh bags. So we end up, we use 50 lakhs to a crore of blood bags, which could be used for the patients. So our details are available on this website, curethalassemia.in. We have many apps which we have created, including anemia diagnosis, thalassemia diagnosis, and thalassemia score also, and AMII. And these apps are available free of cost, including for monitoring patients on our therapy. And these are the contact details for all of you who want to contact us. Thank you very much.